كله قولي دي مش بتاعتي. ودايما بنسعد بحضرتك معانا يعني والبرزنتيشنز الجميله بتاعت حضرتك. كان ناوي بريزنت استاذ دكتور وسام الزيات، عضو من اعضاء التيتشنج تيم من ابوريش بيدياتريك هوسبيتال ورفيقه الكفاح على مدى سنوات طويله يعني، وهتقدم لنا كده محاضره عن الهيباتيك ايميجينج. اتفضلي.
مساء الخير. Thank you Dr. Hadil. I'd like to thank Dr. Hisham the Radiology Department in Benha University for the kind invitation. ولازم اسجل برضه اعتزازي كده زي دكتور هديل بانتمائي لمستشفى بوريش. Today I'm discussing the pediatric hepatic imaging approach. One of the common mistakes in pediatric radiology in general, مش بس في الهيباتيك imaging, is to consider children as little adults. They cannot be considered a miniature of an adult pathology or an adult physiology. Children are different than adults in so many ways. There is, of course, the specific etiology, the genetic defect, and the environmental exposure. Children respond to their environment in a different way than adults. For example, we can rarely encounter an adult who has inhaled sound adult, mentally sound adult who has inhaled a foreign body or ingested a foreign body, while in a pediatric hospital we all know that it is an everyday occurrence. This is how they react to their environment. Children also are more susceptible to injury owing to their anatomical and functional immaturity, the bile duct size, the state of development, the difference in acids, bile acids, and even the submucosal and mucosal layers of the liver are not still mature. Their response to injury is no mystery that the immunity and inflammatory response in children has a very higher tone than that of adults. This is particularly notable in the speed of fibrosis progression. For example, a newborn with biliary atresia can develop cirrhosis within a few months and develop HCC within a few years. So when to start pediatric imaging? Like many of the pediatric pathologies, they start in utero. This is a fetal MRI we performed in Abu Rish. We found this left hepatic lobe large heterogeneous mass. At this point, we couldn't tell what the mass is. It could be hepatoblastoma, hemangioendothelioma, maybe even mesenchymal hamartoma. We were waiting for this baby to be born, but sad enough, his mother had stillbirth, which may lead to the assumption that it might have been a hemangioendothelioma. This is the kind of pathology that puts the fetus in hemodynamic stress. Which imaging modality to use? This is still a dilemma. According to the Pediatric LIRADS working group, for focal hepatic lesions, ultrasound is the initial assessment. Perform CT or MRI for multiple lesions, if the lesions are too deep, if they are large enough, or for follow-up of benign tumors. And never to use ultrasound for the assessment of tumoral response. This is considering focal lesions, but for chronic liver lesions, still there is no consensus screening recommendation for chronic liver disease provided by the LIRADS group. We can use, of course, ultrasound as screening. We can add Doppler, elastography, or MRI. So one of the dilemmas, whether to use triphasic CT or dynamic MRI. Of course, the greatest taboo, as Dr. Muhammad said, is the ionizing radiation, and we should avoid it all the time when it comes to pediatric radiology. But this does not mean that we should discard CT altogether. CT has several advantages. It is faster, less sensitive to motion artifact, there is less need for sedation, and it is better if I am to perform CT angiography or pertography. Still, MRI has the greatest advantage of lacking ionizing radiation. Also, we can provide with MRI many sequences, other sequences like in phase, out of phase, Dixon imaging, R2 star, T2 star, many sequences can be added, and there is new advanced motion insensitive sequences in MRI used nowadays. It is superior for soft tissue contrast resolution, and it is, of course, optimal when there is a need for repeated exams. If a child is expected to have repeated exam along his life, of course, MRI would trip CT in this case. So how to approach a case? The question is whether the lesion is focal or diffuse. For focal lesion, decide whether they are cystic or solid, and for both solitary or multiple. For focal cystic solitary lesions, we have the congenital ones, like congenital hepatic cyst. These are simple cysts, usually asymptomatic. They have all the criteria of simplicity and rarely need any management. So are ciliated foregut cysts, but they have a typical location in segment 7. Inflammatory lesions, pyogenic, amoebic, or hydatid lesions. Pyemic abscesses have the characteristic double target sign and the cluster signs, the multiple low attenuation lesions in a localized area. Amoebic abscesses are a little bit difficult. Sometimes they cannot be differentiated from other liver abscesses. They may have an incomplete rim of edema. The margin may be smooth or nodular, and internal septations are present. Hydatid cysts are more distinguishable. This could be by the frequent peripheral focal areas of calcification, the septi and daughter cyst, the water lily sign, and the spoke wheel pattern. Traumatic lesions, the biloma. We should establish a communication with the biliary tree better by MRCP, and hematoma with the characteristic hyperattenuation, and sometimes you can see the active extravasation of contrast on imaging. Neoplastic, focal, cystic, and solitary are mesenchymal hamartoma. They occur in a younger age group, uncommon, and they are usually cystic with soft tissue component. Undifferentiated embryonal sarcomas in an older age group, under 15, they have a significant necrotic and cystic component. For focal cystic multiple lesions, still the congenital ones like Caroli disease, multiple cysts of the intrahepatic bile ducts. They are type 5 choledochal cyst according to the Tudani classification. They may be diffuse, lobar, or segmental, and common associations are the medullary sponge kidney, autosomal dominant, and recessive polycystic kidneys. Inflammatory lesions, pyogenic abscesses can be multiple, but fungal abscesses are usually multiple, sometimes even miliary. In immunocompromised patient with the delayed ring-like enhancement. Cystic metastatic lesions are not common in children. Back to the classification, for focal, solid, and solitary lesion, a very useful stratification is according to the age group. We have children less than 6 months, 6 months to 6 years, and older children above 6 years. Consider infantile hemangioendothelioma in these in less than 6 month patients when the lesion has the peripheral enhancement with gradual filling in, and characteristic finding is the mid-aortic syndrome, which is the reduction in the caliber of the aorta just distal to the celiac trunk owing to the shift of blood towards the liver. Also consider hepatoblastoma, the commonest of the malignant lesions, usually heterogeneous with areas of necrosis and hemorrhage and chunky calcification. In 6 months to 6 years, consider embryonal rhabdomyosarcoma. These are heterogeneous hypoattenuating masses but associated with bile duct dilatation. Older children are a little bit like adults, hepatocellular carcinoma, focal nodular hyperplasia, and hepatic adenoma. Regarding HCC in children, there are numerous predisposing factors for HCC, glycogen storage disease, tyrosinemia, biliary atresia, portosystemic shunts, Alagille syndromes. Many syndromes can be precursors of HCC. But it is worth noting that HCC can be sporadic in children. It's not an uncommon occurrence. It accounts for 33 to 50% of cases of HCC. HCC, as regarding the imaging, finding would be typically like that of adults. On unenhanced CT, isodense or slightly hypodense. On enhanced CT, they show the arterial enhancement and rapid washout with tendency of invasion to vasculature. Focal nodular hyperplasia are rare in children. These are slowly growing tumors without malignant transformation, and they are rarely accompanied by complications like hemorrhage or a rupture. So we better conserve and wait and see is the strategy. There are no fat calcifications or hemorrhage. They have an early arterial enhancement with the spoke wheel pattern of central speeding vessels. They become isodense or isointense to liver parenchyma on the portal phase with no evidence of central fibrosis. Hepatic adenomas, usually in teenage groups, mostly sporadic, but they can be multiple with genetic conditions or adenomatosis. The pattern on MRI will depend on the degree or amount of fat, hemorrhage, and necrosis. The fat component is usually well demonstrated in in-phase, out-of-phase sequences with the drop-off signal in chemical shift sequences. They are heterogeneous with high signal on T2. They have still early enhancement, but they shouldn't have much of an early watch out as that of HCC. Back to the original classification, the focal, solid, multiple lesions. Hemangioendotheliomas can be multiple. Metastasis, multiple, usually from neuroblastoma and lymphoma. But lymphoma rarely involves the liver exclusively. There must be other lesions, other nodal groups, spleen, kidney. Diffuse liver pathology. Many etiologists can cause this: cholestatic, viral, autoimmune, hereditary, or metabolic. This would lead to fibrosis, and fibrosis would eventually lead to cirrhosis. It's very important to stop at the stage of fibrosis. The early detection of fibrosis is very important, as clinical stabilization or even reversible can be achieved with adequate treatment. So what's fibrosis? Fibrosis is actually the accumulation of fat, excess protein matrix as a form of inflammatory response, and iron in repeated blood transfusions. One of the important aims of imaging is to quantify this fibrosis. This aims at avoiding liver biopsy. Liver biopsy, though, is still the gold standard in the quantification of liver fibrosis, but still it has many adverse effects. We are talking about infection, hemorrhage, pneumothorax, injury to another organ, sometimes the creation of an iatrogenic arteriovenous fistula. So imaging is important to quantify this kind of fact. NASH is a very rising concern. Actually, those chunky babies are not, they are actually destroying their livers with fat. Hepatologists, gastroenterologists they have a major concern regarding NASH. And of course, not just because an obese patient, we're gonna run and go do biopsy. So there is an urge of imaging techniques and non-invasive imaging techniques to quantify this fact. We use the ultrasound based for quantifying the attenuation of ultrasound beam. This is a normal child and a child with fatty infiltration. You can see, of course, the difference in echogenicity reflected in the attenuation coefficient, as well as the hepatorenal index, the difference between the liver and the kidneys. Shear wave elastography is an accurate and reproducible, non-invasive, very important non-invasive technique for the efficient detection of liver fibrosis in children with NASH. It is simple, fast for the stratification and follow-up of these patients. MRI proton density, fat fraction, and MRS. These are T1 independent, T2 star corrected multi-echo Dixon technique. It's very important to be T1 independent, as for the bias. We all know the bias of T1 to fat. This would quantify fat to water content either in a region of interest or for whole liver segmentation. MR spectroscopy uses multiple echo times with, to calculate the T2 corrected lipid fraction. This comes up with a fat fraction. Here it's 3.7, for example, which is higher than normal. We can see up to 40%. The multiparametric MR index, it combines MR spectroscopy, MR elastography, and T1 mapping to come up with a non-invasive MR index. For NASH, it is higher than 6, and non-NASH lower than 6. MRI R2 and R2 star mapping, hepatic iron overload is a major complication in repeated therapeutic blood transfusion in children with chronic hemolytic anemia, and we all know how prevalent that is in Egypt. It is a high risk factor for liver morbidity and damage, and therefore we need to carefully monitor the concentration of iron to adjust the proper timing and dosage of chelation. We use this technique to come up with the LIC, the liver iron content, and then we stratify it into normal, light, moderate, and severe accumulation of iron. So in short, in Abu Rish, we have our own strategy. It's always to reset to pediatric radiology, not that simple, communicate with fellow physicians, and always search, and then think again after we search. Thank you very much.
Thank you very much, Professor Wesam. Very nice illustrative presentation. Now I'll introduce the next speaker, Dr. Hind Gamal.